Share screen. No. Wrong screen. Share screen. That screen. There we go. Okay, so do y'all see my PowerPoint now?
Yeah, we can see it.
Okay. Let me get rid of all these extra windows. And let me make it bigger. And here we go. Okay, so today last week you talked a little bit about motor learning and sensory integration and a little bit about how some things work. Well, today we're gonna go over a little bit of review, put that into different words so that it can make sense. And then the second part of the lecture, after we take a long break, will be how to get motor recovery back after an injury and how the brain responds to rehab and how the brain heals itself and gets motor function back. Because whenever you have a neurological injury, it's not so much the muscles that are weak. I mean, they are weak, but they're weak because of the brain can't control them. So we need to work on the brain. We need to work on the spinal cord whenever those things are happening. We're not so much doing weightlifting and things like that with TheraBand and stuff. Okay. So motor control, when you think of motor control, look at these two pictures here. It's motor control involves neural control, physical control, and behavior. And all of those things have to be present to result in the proper posture and the proper movement. So the brain is involved, the body is involved, and the brain is involved physically with the lobes that control the muscles, but then the brain is also involved behaviorally because we have to consciously say to ourselves, hey, do I want to do this? Or in this middle picture here, these women are carrying large baskets of food or something on their heads, and that's how they carry through the market. So they have to purposefully balance those things and hold on to those things as they walk home. And so it's a behavioral process. They have to know what they're doing. If they forget those bags are up there and then they suddenly make a sharp turn or start running, they're probably going to fall off. Okay, so some elements of motor control are genetically based, like our primitive reflex patterns and our primitive movement patterns that we develop as a baby, and then all the reflexes that emerge, and then some that go away. Those are genetically based. But the rest of them are gained through interaction and exploring our environment. So just as babies play with their toys all the time. Well, that's play, but they're also interacting with their environment. They're learning what things feel like. They're learning how they can squeeze things. They're learning how heavy things are and things like that. So they're interacting and exploring their environment. And it's all about practice and feedback. The more they do something, they're going to learn that motor skill quicker. And if they get feedback, like say if the baby touches his favorite toy and it's soft and he likes soft things and it comforts him, he's going to know, oh, every time I reach, he might not be able to say this thought in a sentence, but he'll learn over time, hey, that stuffed animal is soft and I like it and it comforts me. So that's his feedback that he's getting, that, hey, that dog, I remember that animal is soft and I like it. So that's the feedback that we gain. And just another example of that, of motor skills are a specific movement or a specific combination of movements that have one goal in mind. So let me break that down for you. It's not as hard as it sounds. Right now, let's look at the middle picture right here on the bottom of your screen. The baby that looks like it's on all fours, and the mother is asking it, looks like she's coaxing it to come to her. Well, that's a motor skill that requires a lot of practice, requires a lot of sensory information, and after the baby's practiced this a few times, they can do it, and then it's a motor skill. They've learned it by practice and by their CNS organizing things. Let's look at this picture of this little child playing hopscotch. Let's don't look at every single little hop individually, but let's think about the whole game. In hopscotch, you hop from 1 foot to 2 feet, from 1 foot to 2 feet, from 1 foot to 2 feet. So that whole thing is a motor skill. You could break those down and say, hopping on 1 foot is one motor skill, and then hopping on 2 feet is one motor skill, which they are. But the whole motor skill itself is being able to hop from 1 foot to 2 feet to finish the game. So that would be the motor skill. I believe you learned a little bit about feedback and feed forward in your recorded lessons, but just remember that feedback is information you get after you've performed a movement once or twice, and it's feedback to your body on how you can make that movement better. Feed forward is already knowing the adjustments you need to make. Like it's anticipatory. So you see a ball coming toward you, and you widen your stance and you stand up straight and you put your arms up and you get ready to catch it even before the ball gets there. So that's because if you don't do that, the ball's going to hit you. So you have to anticipate and have feed forward to catch the ball. And coordination is just like we said the word coordination to ad nauseum last week. All of that means, you can just see here, the ability to make all that work together and perform accurate and controlled movements. All coordination is. Okay. So we've already talked about motor learning. It just comes from practice and experience. The more a person practices, and we use the examples of toddlers earlier, but the more a baby practices a motor skill, the better they're going to get at it. They won't crawl just the first time they get up on hands and knees. It's going to take them a few times, but then after practice, they've got the experience, and then they can do it. That's all this slide is saying. Motor learning can vary from individuals due to genetics and life experiences. So some people are just genetically stronger than other people with life experiences. You know, there's some motor movements and tasks like household chores and things that might have to do with agriculture that poorer countries do normally. But then there's things in richer countries that we don't do normally. So go back to that slide where the women were carrying the baskets of the food or water on their heads. All over the world, that's how people carry heavy loads. And that's a very common motor task for them. And they know how to do it. They can balance it. They can walk fast. They can change directions. And that stuff does not fall from their head. But if you came over to the US and asked just any one of us to do that, well, if you took a person the same age, same sex, same everything as the person that could do it in another country, have somebody in America try to do that, and they would never be able to balance the basket on top of their head. They'd fall, they'd drop it, and everything. So it does have to do with life experiences too. Okay. Sensory information guides and shapes motor programs. So this is all what the sensory integration videos were about. So you can think of the brain's movement patterns as little. Let's think of it as coding in a computer. Okay, so think of all your neurons connected to your axons, and they're all an interconnected computer. Okay, and there's code written for everything that we do. Well, a motor program would be just the representation on the brain that controls that movement. A motor plan could be several motor programs that come together to make up one motor movement. So look at this dog catching a frisbee. On that dog's brain, he's got motor programs for running. He's got motor programs for jumping. And he's also got motor programs for aim that he's learned from just practice over and over. So those are all separate motor programs. Well, unless he puts those motor programs together, he will never catch the Frisbee. Catching the Frisbee is the motor plan, okay? The motor programs are the individual parts that make up, that allow the person or the organism to do the motor plan. Okay, motor memory is just what it sounds like, the recall of motor programs, how it looked, how it felt, how it sounded. And the more you do a motor program, the stronger your motor memory will become. Okay, here's a very important word that you all need to know. And if you're not paying attention thus far, stop what you're doing and pay attention now, because this is a very important word and I will talk about it every day from now on. Neuroplasticity. Okay, neuroplasticity is the capacity of the brain and sometimes the spinal cord to basically adapt to injury through repairing and changing itself. So think of it as forming new neural pathways. The brain is rewiring itself in response to injury. So sometimes when the brain is injured in response to like a stroke or a brain injury, or even like Parkinson's or MS, we lose a motor program or we lose some of that wiring between connections. Well, neuroplasticity is the brain's way of healing itself and healing change. So sometimes neurons will resprout axons, and those axons will regrow into other axons to kind of make up for the axons that were cut, or new pathways form in order to fix the problem. So that's how the brain heals itself, through neuroplasticity. Okay, let me come back to this a little bit. I'm going to say this in a minute, but the way you get neuroplasticity to actually happen in the brain is through repetition of movements and repetition of motor programs. So if you're in therapy with your patient and you're doing exercises to do something to make something work better or do something better, the more you perform that activity and the more practice they have, the more neuroplasticity is happening. So neuroplasticity is driven by repetition. So let's look at these pictures here. So if you look at the picture on the people on the treadmill, this is a picture from TIER where I used to work, and this is a body weight supported treadmill system. So this is somebody that's on the treadmill, but they can't stand up on their own. They can't hold up their own body weight. So there's a harness that's holding their body weight up, and then there's people, one person on each leg moving their legs with the speed of the treadmill, and then one person behind them guiding their pelvis and shifting their weight and rotating their pelvis. After time, not just one session, but say 10 to 20 sessions of doing that, the patient may be able to start initiating steps on their own, or they may be able to support a lot more of their own body weight than they could in the beginning. That is an example of neuroplasticity happening. Oh, and the cat. This cat, poor cat, has had a front leg amputated or was only born with one leg. Well, let's say that this cat was born with 4 legs and it was normal. Well, then it was in an accident or broke its leg and it was amputated. Well, this cat can still walk. Cats and dogs with 3 legs can still get around, but there are going to be changes on this cat's brain because it's going to have to walk differently. At first, when it has this amputation, it's going to be a lot slower. It's going to be hopping and hobbling along, and it might fall over a few times. But the more that cat practices walking on 3 legs and goes through daily life, that cat is going to get better at walking on 3 legs. And then eventually it won't lose its balance anymore. And it'll be able to go up and down stairs and run and bend down, or maybe even stand up and climb things. Maybe not climb things, but after a while, that's neuroplasticity happening in that cat's brain. At first, it couldn't do things, but the more the repetition of movements and trying things makes new pathways. So don't forget that word. If you ever forget that word, I will be very disappointed in you. Okay, I will let you look through these a little bit on your own. I'm not going to go through these in very much detail, but these are just a couple of motor control theories. Basically, I'll just give you the summary of them. The dynamic systems control theory says that units of the central nervous system are organized around specific tasks. So that means that there might be simple areas, small parts of the brain may be needed for small activities, where the whole nervous system may be needed for complex activities. The hierarchical control center says that the central nervous system is organized into higher, middle, and lower levels, and that it's a top-down control. So that they mean the highest level being the motor cortex and the cerebellum and the basal ganglia have the highest level say. Then the middle level components, which would be some of the cerebellum and the brainstem, might modify the programs, and then the spinal cord would actually execute the movement signal to the muscle. So those are two theories. Just read through those on your own to make a little bit more sense. There's not really, we have definitive evidence. Well, not definitive evidence, but we have a little bit of evidence for both of these. But there are some schools of thought that they agree one more than the other. So I'm not trying to sell you on one. Just look at them and see the difference in them. You know that lesions in specific areas of the nervous system are going to produce specific deficits consistent with that area. But the outcomes may be very different. So let's say that, and I'm going to pick on Shantae because I can see her on my screen right now. So let's say Shantae and I both had a cerebellar. We both got hit on the back of the head with the cerebellum. And we both had a cerebellar brain injury. Well, if y'all can remember for last week, our deficits should be pretty consistent. We should both have some ataxia, which is the shaking of the limbs with intentional movement. We should have some problems with our coordination, maybe some global weakness, and some postural weakness. Both of us would, more than likely. But our outcomes, now I'm going to go to the next bullet. Our outcomes at the end of therapy could be very different because of neuroplasticity, recovery, and functional outcomes. So plasticity, remember, neuroplasticity has to do with repetition. That's how the brain forms new pathways and heals itself. So let's say that Shantae and I went to different therapy facilities. Shantae got a lot more training for her ataxia, got a lot more pull therapy for resistance training, and got a lot more gait training. And then where I went, I just got the basic gait training, not a lot of stuff. They didn't really know how to treat my ataxia, so they did the best they could. And then let's say we stayed in therapy the same amount of time. Well, in the end, say 3 months later, who do you think is going to be doing a lot better? Shantae's going to be doing a lot better because her brain was giving more specific things to address her ataxia and her weakness, whereas my therapist just did general things. And Shantae's therapist may have had her coming more than a few times a week, and I just might have went twice a week. So at the end, Shantae's going to have way better outcomes than me, even though we had the same injury. Okay, motor function examination. So this is going to be something that you might think a motor function exam is done at the eval, and the PT is going to do that, but you should always be kind of always assessing your patient's motor responses, no matter what you're doing. So CNS responses, anything to do with the nervous system, how the patient reacts to any kind of new sensations. We'll talk a little bit about compensatory mechanisms in a minute, but compensatory mechanisms are basically substitution patterns where they're doing things the wrong way just because their brain, they say they don't have full use of their arm, so they hack their shoulder up and lift their neck a lot to reach something in the top of the cabinet. That's the wrong way of doing something. That's compensatory. So part of this, I don't have to tell you this, you've all been on clinical so far. So you've been on 2 clinicals, so one clinical so far, I'm sorry. You've all had to look at a chart and do a patient systems review and status review, test and measures. You probably looked at evals before, so we won't go through that. We went through consciousness a little bit last week when we talked about the Glasgow-Coma scale and the levels of orientation, like being obtunded and stupor and minimally conscious. We talked about those things. Orientation, we talked about that, just if they're oriented to their person, place, and time. And then executive higher level cognitive functions would be like speaking properly, being able to make decisions for themselves and being able to count, abstract thinking, things like that. Arousal, we went through all of this stuff, so I'm going to skip through it. I do want to stop here for a second. On assessment of loss of consciousness, whenever they are doing the Glasgow-Coma scale on a person, that test we talked about last week to determine how severe their brain injury is, they're going to be looking at their heart rate, their blood pressure, their respiratory rate, their pupil responses, and if they're sweating or not. Okay, besides asking them questions and then seeing if they respond to pain and things like that. That'll always be done at the scene and maybe in the ER too. We talked about the sensory integration being a feedback system, a loop system. Okay, now we're going to change gears a bit. Any questions what I've talked about so far as far, this was review, but as far as just motor learning and neuroplasticity and things like that? Okay, there you go, good. Okay, so let's talk about tone. Y'all know what hypertonicity is, and you know what hypotonicity is, and you know what normal, that we all have normal tone, but what exactly is muscle tone? So let's talk a little bit about what that is. Okay, so everybody has a normal amount of resting muscle electrical activity going on. So our brain is always sending a certain amount of electrical impulses through our nervous system to our muscles. And that gives us a certain amount of resting tone. So our muscles aren't just floppy when they're turned off, but they still have a little bit of some kind of stiffness in it. Some of the actin and myosin filaments are bound, just a little bit, not as much as in a full contraction, but just barely bound. Okay. So that's what tone is. Well, when you have a neurological injury, your tone is going to be changed. So you can either have hypertonia, which is high tone, hypotonia, which is low muscle tone, or dystonia, which is disorderly tone. And let's talk about all of those here. Okay. So everybody look at this picture, and then the 2 yellow bullet, where it says anterior horns. Let's talk about this picture for just a couple of seconds here. Okay, upper motor neuron lesions and lower motor neuron lesions. Do y'all remember what the differences between those are? Anybody?
Say again.
Anybody remember the differences between upper motor neuron and lower motor neuron injuries?
What? Oh, no.
Is it sensory versus motor?
Not quite. Okay, this might be new for y'all. So let me tell you. Okay, so think about, y'all all did your spinal cord tract project, and then and your brain project. Well, when you were doing your spinal cord tract project, you may have noticed where when you were looking up your information, that a lot of the information told you where each tract crosses in the brain. And when I say crosses, it means either crosses to the other side of the brain in the brainstem before it goes down the spinal cord, or sometimes those fibers will actually cross to the other side in the spinal cord itself. Okay, well, stay with me here. In the spinal cord, there are between the neuron, there's always going to be a neuron coming for everything, coming down from the brain, and then it's going to synapse with a new neuron in the spinal cord. And when I say synapse, that means it's going to meet that new cell in the spinal cord. Well, that cell that it meets in the spinal cord is called the anterior horn cell. Okay, that's where the spinal cord tracts pick up the brain impulses. Well, if the injury to the person happens between their brain and the anterior horn cell, if you can see my mouse moving, let's say that's right here. Y'all see my mouse moving?
Yep.
Okay, let's say that's where the anterior horn cell is, or that's where the lesion happened. Well, if this is the anterior horn cell and this is where the lesion happened, the brain is still connected to those pathways, but the spinal cord is not. Whoops. Okay, so but the spinal cord is not connected to those pathways. So the brain has no way of getting its signals from the motor cortex to the muscles to make movement. So that's where paralysis comes into play. It's the same thing with lower motor neuron injuries, except this time the lesion took place in the periphery after the anterior horn cell. Okay, so in this case, the brain does get information to the spinal cord like it's supposed to, but in this case, it can't relay that information from the spinal cord to the muscle. Okay, so those are two different types of injuries. Now, let's back up again, and let me tell you how these are different. If the injury happens between the brain and where the fibers cross at the anterior horn cell, you're going to have what's called an upper motor neuron lesion. Okay, it's upper motor neuron. It's more up top in the nervous system. If the lesion or injury happens between the anterior horn cell and the muscle, say down here, then it's going to be called a lower motor neuron injury. Okay. Now, there's a big difference between these. If you have an upper motor neuron injury, your brain can't tell your muscles to calm down. So your spinal cord is still connected to your muscles, and it's always sending signals to your muscles to come on. So that's called hypertonicity. Your muscles are overactive, even when you don't want them to, because your brain has no way to tell your muscles to turn off. Okay. If you have a lower motor neuron lesion and it happened below the anterior horn cell, the brain is sending signals to the spinal cord for that movement, but the spinal cord cannot send anything to the muscle. So the muscle is going to be floppy and it's not going to have any electrical activity going to it. That's called a lower motor neuron injury. So upper motor neuron injuries have tight muscles, uncontrolled muscle contractions. Lower motor neurons have floppy muscles and they can't turn on their muscles because they don't have any control, any connection to the brain. Now, did I lose anybody on this slide with that explanation? Because I just threw a big pot of info at you.
Quick question, Mr. Allen.
Okay.
So for upper or lower motor neuron injuries, which one for like NMES would be better? I know one of them, NMES won't like work. So which one of those?
Perfect question, Willie. Very good question. You remembered that from semester 2. Willie gets points for today. If you are doing any NMES on a person, you can do it on an upper motor neuron lesion because there is still connection to that muscle to the spinal cord. So remember, we did learn we learned that there is some possible neuroplasticity that happens in the spinal cord. Not much, but it's possible. So the spinal cord, if we're doing NMES to a muscle that's got hypertonicity, we could either do it to the hypertonic muscle to tire it out so that it won't be so overactive, or we could do it to the antagonistic muscle to get it stronger so that the overactive muscle is not always overactive. Okay, but if we wanted to do E-stim to a lower motor neuron injury muscle, that would be a floppy muscle. We're basically not, the only reason we would do that would be to prevent the muscle from atrophying for cosmetic reasons. If it's a lower motor neuron injury and that muscle has no connection to the brain whatsoever, that muscle's not going to come back. And so it's going to be very floppy, and it's always going to be very floppy. So if you did NMES to it, it'll contract with the NMES, but they'll never be able to contract with it on their own. So they might just do it on their own at home just to keep their, say, for their leg or their arm from atrophying so it doesn't look funny. So maybe for cosmetic reasons. Okay, so if you don't quite understand, or if after today you don't remember the difference between upper motor neuron and lower motor neuron syndromes, look back at the slide, and I've got another slide coming up that'll help you. Okay, let me look at this. Here's the chart that I was looking for. So on one side, it's got upper motor neuron lesions, which is almost everything we're going to talk about this semester, all of the different pathologies. And then we've got the lower motor neuron lesions, and it's got a few of those pathologies. Those are mostly peripheral nerve injuries. And you can see who's got spasticity, who's got flaccidity, who's got atrophy, who's got hyperreflexia versus hyporeflexia. Upper motor neuron lesion people will tend to have pathological reflexes, and those infant reflexes return, where lower motor neuron people will not. And clonus, which we'll define in this slide, is kind of like a shaking, but it's not like ataxia coming from the cerebellum. Okay, so let's talk about this slide, all different types of abnormal tone. We'll take a break in a minute, guys, I promise. Types of abnormal tone, and these are all going to be, almost all of these except for one is going to be hypertonicity. So spasticity, sometimes you'll hear people say spasticity, hypertonicity, tone interchangeably. They use the words the same way, but they do have a little bit of a difference. Spasticity is how a muscle resists you in response to passive movement with velocity. So like if I was a therapist, and I'm going to try to do this in my camera where y'all can see me, and I was testing, let's say Midden's tone of his biceps, okay? So, there's a video of the modified Ashworth test that I want y'all to watch for this. I would put Midden's arm in a short flex position, and then over a 2-second 2-second stretch, I would quickly extend his elbow, stretch his elbow out. What I'm doing, I'm measuring the resistance that his bicep muscle gives me. So on all of us, if we were all holding ourselves, a patient like this, and just did this, extended them real quick, we might get a little bit of a catch at the end, but it's just going to go smooth. Somebody that's got spasticity, it's going to be like, it's going to give a little bit and then contract, and then give a little bit and then contract. That's what class knife response means. It's going to give and then contract. Or and sometimes we may not even be able to get it through the whole range at all because the muscles are just so tight and active. Clonus is another symptom of upper motor neuron spasticity. Clonus almost always is occurring in the ankles, in the ankle plantar flexors, and in the wrist flexors. And it's basically just a constant shaking or a beating. So like, you know, like a lot of us, if you're sitting like a long lecture or sitting for a long time, you pump your ankle up and down or shake your ankle. That's exactly what clonus looks like, except you don't have clonus. You're just being impatient or trying to move around. We all do that. But people with upper motor neuron lesions could be sitting in their wheelchairs and their feet are just bouncing up and down. They may know it, they may not know it. Sometimes it will be there it just might be in response to, like, if you reposition them in their wheelchair or you transfer them to their wheelchair, it'll kick in for a minute and then it'll die down after a few minutes. Okay, you know what the Babinski sign is. Rigidity is just a type of spasticity or hypertonicity that is a full contraction of the agonist. So if you can see my bicep, the agonist and the antagonist. So it would be a co-contraction on either side of the joint. And no matter what you as the therapist do, you cannot move that joint. That's not permanent. That's just in the moment. A few minutes later, if the patient's in a more relaxed state, you may come by and then you can move that same joint through its whole range of motion with no trouble. Just spasticity kicks in sometimes and sometimes it goes away. It does its own thing. It has a mind of its own. We already defined hypotonia as with lower motor syndrome. Dystonia. Okay, so dystonia is a type of hypertonicity that happens in different postures. So sometimes it usually happens with this says, okay, let me rephrase this. It says dystonia is a prolonged involuntary movement disorder with twisting or writhing repetitive movements. Okay, that says involuntary movement, but let's say a person with a stroke is sitting there in front of their table and they are about to get ready to eat their dinner. Well, let's say I have a little bit of dystonia in my upper extremity with my right arm. Well, I lift my arm up and I go to reach my fork. Well, as soon as I get way out there distally, my dystonia kicks in and then it flexes, and then it does the classic stroke flexion synergy. It flexes my fingers real hard and curls my wrist and deviates it and internally rotates my shoulder. And now I can't reach my food anymore. So somebody has to come over, stretch me out. Then I try again. And then maybe I'll be able to eat that time. Maybe I can eat a few times, but then after a few more minutes, I'll go to reach for my food, and then that movement pattern will take over, that involuntary pattern will take over, and I won't be able to control my arm anymore. That's what dystonia is. It usually involves multiple joints on the same extremity. And it mostly comes from something to do with the basal ganglia. So lots of stroke patients have dystonic posturing. Lots of brain injury people have dystonic posturing. Those are the main people that have it. So if they do get any of their injury to components of their basal ganglia, they can definitely just get some dystonic posturing. And the posturing, just to again remember, the posturing is the term that we use in the neuro world to talk about abnormal movements or positions that are involuntary. Focal dystonia would be one body part, and segmental dystonia would be two body parts, but they would usually be adjacent. So I could have dystonia of just my wrist and my fingers, or I could have dystonia of my wrist, elbow, and shoulder. Any or all of those in between. And there's really not a rule to say what'll happen when, because every single injury is different. So everybody's going to present differently with different dystonias. We talked about discerebrating this corticate posturing last week. So do y'all remember this picture? Did I show y'all this last week?
I don't think so.
That was in another lecture that I recorded. I recorded y'all's brain injury lecture last week, and now I'm thinking I've already did it. So sorry. Okay, let's talk about more abnormal tone. Sorry for my little brain fart. And then we'll take a break, I promise. Dyssynergistic movements. These are just a dyssynergistic movement. Just look at the word dys means bad or abnormal. Synergy is a group of muscles working together. So this is a bad synergy. This is a group of muscles working together, but it's not happening in the right time with not the right timing, not the right muscles working, and not the right kind of strength and dexterity. Okay, so a couple of examples of dyssynergistic movements are any kind of dystonia, any kind of dystonic posturing. So like that stroke synergy I said, that the stroke dystonic posturing looks like this. It's elbow and it's shoulder flexion, elbow flexion, shoulder internal rotation, wrist and finger flexion. Like I'm keeping my fist up to my neck or to my chest. That's a common stroke flexor synergy. Or posture. We say synergies or posturing. Okay. In this picture here, these are two specific types of postures I want you to remember. These are when these happen, these always follow the same exact patterns, no matter what. So you've got the cerebit rigidity or posturing and the corticate rigidity or posturing. Somebody got kicked out. Okay, everybody's back. In the cerebit posturing, this is when you have a brain injury and you're laying in supine, usually not very conscious. And this is usually with a severe injury. And all your extremities are in extension, except your fingers, which are flexed. The corticate posturing, the only difference is your elbows are flexed and your hands are resting up on top of your chest. So it looks like a corpse pose. Now that's not that somebody laid them like that. Their body naturally went into that position. Now, if you think how can I ever remember this, the differences between these, the cerebit, that word has a lot of ease in the word. Well, in the cerebit, you're extended, and extended starts with an E. So always remember the word that has a lot of ease in it means the body is extended. The corticate, that's the only one left, just means flexion. So just remember the cerebit, lots of ease means the body is extended. You'll always see different posturings and dyssynergistic movements with central nervous system injuries. But if you see the cerebit and the corticate posturing rigidity, those are usually indications of very bad injuries and poor outcomes. We talked about spasticity. You saw this chart. Let me see what I need to tell you here. This is all that's saying when you look at somebody's tone, I do want y'all to watch the video on the modified Ashworth scale testing tone. If we have time in lab, we'll go through it. But one thing I want y'all to get from this line, don't just forget about looking at all these crazy words on the slide. Before you test a person's tone, if you're gonna look at somebody's tone or their strength before your session, this doesn't mean you're doing an eval or a re-eval or an exam. You're just getting an idea of what they're like from 1 week to the next. I mean, you can do that. Don't stretch them first to get their range of motion measurement. Don't get their strength tests measurements and then their modified Ashworth or tone test. You've got to always test their tone first, because tone is an animal all of its own. If you stretch a muscle out, it's not going to have as much tone. And if you have a muscle strengthening or do strength MMT on them, it's not going to show its real tone either. So if you do those things and then do tone testing, you're not going to get accurate scores. So whatever they look like when they sit or lay on the mat, you do your tone testing first. Watch that video, and hopefully we'll have time to go over it in lab this week. Muscle performance, blah, blah, blah. Well, really, all this says is that last semester, we taught y'all how to do MMT on the whole body, manual muscle testing. But in the neuro world, you may not be able to use manual muscle testing, and you may not be able to use those standard positions that Ms. King may have taken some points off for if you didn't get it quite right. You might have to make your own positions or modify it. Why? I'm here to tell you that all neuro patients, most of them, they can't get in all of those formal testing positions that we want to get them in. I mean, imagine yourself being a spinal cord patient. You can't go through a whole eval sitting on the edge of the mat, keeping your balance, and then lying down, and then side lying, and then prone, and then in standing. You can't do all those things. You can't get into all those positions. Or maybe a patient, because of a surgery or some kind of precaution, they can't get into one of those positions. So you have to do the testing a different type of way. We always try to do our manual muscle testing in the proper positions, but sorry. What's going on? Can y'all see me?
Yep.
Okay. Did y'all hear my call?
Yeah.
Sorry, I thought I had do not disturb on. I'm just a popular guy. What can I say? Anyway, so what I'm here to tell, all I'm here to say is that you're going to have to do your strength testing in different positions. And if you do it in a different position or modification, you can't use the numbers anymore. So like if you test, say your patient is a spinal cord patient and they're very weak, well, sitting on the edge of the mat, if you want to test their hip flexors, they're probably not going to be able to flex their hips against gravity. But if you put them in side lying, maybe they can. But I'm here to tell you that in the Asia, which Asia is the American Spinal Injury Association, their standard scale for measuring strength of the hip flexors would be in supine. So with the leg externally rotated. So that's not a true, that wouldn't be a true 3 out of 5 or 5 out of 5. That would just be ability to move. You would write it basically as a sentence, like ability to move through this much of range of motion in supine or in sideline. You can't give them a true score if you have to modify the positions. Spasticity is going to mess up your strength scoring. You may think they're stronger than they really are when it's really spasticity. So, you know, the first few times you test somebody and you think they're strong everywhere in their hemiparetic side, don't be fooled. It's more than likely their spasticity taking over. Voluntary movements, abnormal synergistic patterns, that's just the different patterns of movement. That's just examples of the dystonia I talked about, flexor synergies, extensor synergies, and stroke. We'll talk about those. Those are just synergies of our muscle patterns, but they're a type of abnormal posturing, but sometimes the flexors are all like this taking over. And then sometimes the extensors are all taking over and my arm is all back behind me and my hands are open and I can't control that. Or maybe my quads are completely extended and I can't bend my knee. That would be an extensor pattern. Functional mobility skills, it's always good to look at people's tone and what they and how their spasticity is affecting them through functional skills. So don't just waste your time doing simple manual muscle testing and range of motion when you know what they're there for and you know what their goals are. So let's look at their mobility during real life things. Let's have them do some bed mobility, not instructing them on it. Let's just put them on the mat and say, roll over. Can you get them prone? Watch them transfer a few times. I promise you, people that transfer themselves at home are never going to transfer the safe way that we teach them to transfer. They're going to be taught somewhere, but then they're going to develop their own bad habits and do things their own way. Some people will just never lock the brakes. Some people just throw themselves out of their chair. It's scary the things people do, but it works for them. Walking and stair climbing, they're going to have all kinds of deviations with hypertonicity if they can do those things already. So just watch them and see what it looks like. You know how to analyze gait, so you would already know how to analyze it. Mobility skills, that's just going from high to low activities, and we'll be doing some more of those things in the next few labs, going from low level activities like bed mobility all the way up to like prone on elbows, quadruped, sit to stands, and things like that. We start that in lab this week. Almost done with this PowerPoint, then we'll take a long break. You know about postural control. So you know static equilibrium is just sitting or standing and keeping our balance without any kind of bodily movements. We're static. And dynamic equilibrium is our balance and sitting or standing with mobility, either moving our head or moving an arm, reaching for something, bending forward to reach something or get something off the floor, those types of things. Then we have reactive postural control, which occurs in our body in response for something about to happen. And then we say a ball is coming. We react with our body and we get our body ready in our posture to catch the ball. Or proactive or anticipatory postural reactions I'm sorry, I mixed that up. I was reading the wrong thing. Scratch what I just said. Reactive reactions are what occurs in response to external forces on your body. That's how you react in the moment. Proactive or anticipatory postural reactions occurs because you've done this before. You know what to do. Sorry, I mixed those up. You know what these things are. These are your balance strategies, which I know you learned about during Therax. You've got and it goes from little perturbations or when we use the word perturbation now, and when Ms. King and I are going to start using that, a perturbation is just something that moves you all. A perturbation is something that is an external force to your center of mass or your center of gravity. So with a small perturbation, if we're standing, we just use our ankles. We don't really take a step. We don't really sway with our shoulders or hips. Our ankles do it. If it's a little bit bigger of a perturbation, we use our hip. We may sway forward with our hip, our shoulders may go over this way, but all that movement is coming from our hips. Just think if you move any in the middle of your body to keep your balance, but you don't move your feet, that's your hip strategy. And then stepping means you have to actually move one or both feet to keep your balance because the perturbation is that big. And we all use all three of these when we go places like shopping and the grocery store. You go to a concert, you're always using mostly your hip and stepping strategy because everybody's running into you and you're having to keep your balance. These stick figures show me nothing, so I don't want to show them to you either. But you can see just with the perturbations, a little bit of sway with ankle, Bigger sway with the hips, stepping with the stepping strategy. These are just a few of the balance tests that we use in the neuro world. Romberg and Sharp and Romberg, I'm going to have you look these up. I'm not going to go through these tests, but I'm just going to tell you what they are. Romberg is something that's on your coordination video that you should watch in preparation for lab on your lab this week. Sharp and Romberg is standing in heel to toe, like you're walking a tightrope. Romberg is just walking with your feet staggered or standing still with your feet staggered. The Tonetti test is a test for balance and gait. The functional reach test it's for sitting or standing, and it tests how much of a trunk excursion you can make forward and to the side before you need help keeping your balance. And there are norms for different ages and diagnoses, and we can see those. The Berg balance scale is like the gold standard balance scale for stroke and brain injury. It's a 14-item test, and it just starts off in sitting balance, and then sitting with a backrest, sitting without a backrest, standing up, turning around, taking steps. It's 14 items, and you get scored 0 through 4 for each item. And the highest score you get, the higher your score, the better your balance is. The lower your score, the worse your balance is. TUG stands for timed up and go. That's where you stand up from your timed, and the time starts when you stand up from a chair, walk 10 feet around a cone, and then come back to the chair and sit down. And the time doesn't stop until you sit down and your butt hits the chair. This sounds easy, but it's really hard for people when they especially stroke patients, because they have a hard time getting up from a chair. Usually the walking and coming and sitting back down is no problem, but they take a long time to stand up. And the timed walking test, there are many timed walking tests out there. The one that you're probably most familiar with is the 6-minute walk test. That's used with just about every diagnosis. There's the 2-minute walk test that can be used with Parkinson's and geriatrics, just because 6 minutes might be too long for them. And obviously the faster you can go the farther you can go in a certain time test, the better you're doing. And the slower you go, the worse you're doing. And you can keep doing those tests, all these tests, over and over, like every week or every 2 weeks. And you should if you're doing what you should do, all these scores should keep going up. I'm going to let you review this. This is just all about what we talked about, having to have distal, proximal stability for controlled mobility. So remember, your core's got to be strong for your distal limbs to do anything, so you can keep your balance. That's all this means, but you can read through it. You're always going to start when you're teaching motor skills to patients with neuro deficits. And I think this goes without saying, you always want to start off in a stable, constant, non-changing environment. So like a quiet room, or always sitting on the same mat, or always with the same therapist, or always the same type of day, always things like that. Open means doing it in different environments. So after I can walk on tile surfaces for 100 feet with my walker, now let's go out and do it in an open environment. So now let's go out and walk on the sidewalk where it's a little bit unlevel, or let's walk on grass where it's bumpy, or let's walk on a parking lot where there's cracks and there's holes and potholes we have to walk around. That's an open task. And then a dual task is when, okay, let's walk outside on the uneven ground, and I want you to count backwards by 7s, or I want you to walk around the uneven parking lot with your walker, and you have to point out all of the red vehicles that we pass in the parking lot. That's a dual task thing. They're doing something physical and mental at the same time. So any skill that you start off, you always start it off in the most stable, easiest environment, and then you bring on the challenges as they get better, as you get closer to discharge. I've already said motor learning and neuroplasticity just requires experience and repetition. It's not going to happen unless there's repetition. Neuroplasticity will never happen unless there's repetition. And where this says generalized ability, you may have heard this called generalization before. That just means the ability to take what you've learned in one motor task and transfer it to a different environment or skill all by yourself. I don't have to read this all to you. You know motor learning is happening when somebody's coordination and their quality of movement is improving, when they need less assistance from you, when they're making less errors and don't have to use so many substitution patterns, when they can do things faster, when it looks like it takes less effort and concentration from them, and when they're consistent every time. The more they're consistent with their score and the more they're consistent with doing their good performance, then you know motor learning is happening. If these things are not happening, then neuroplasticity and motor learning have not occurred. You can read through this. I do want you to know what the performance plateaus, the ceiling and floor effects are. These have to do with doing outcome measures like tests, like I talked about with the tug and the Berg balance scale. So if there was a test that had the ceiling effect, let's talk about the ceiling effect. Let's say that you have a patient that is a stroke patient, but they had a minor stroke. Well, let's say their first week in therapy, you did the Berg balance scale and they scored with a minor balance impairment. Well, then a week later, they got way better and now they scored a perfect score. Okay, well, that's good. Well, if you keep doing that test on them every week, they're going to keep showing a perfect score. But even though you know they can do harder things, that test cannot show their level of improvement. So they busted through this glass ceiling of that test, okay? That test can't show any more improvement. So they need a much more difficult, higher level test. The opposite of that is when a test is too hard for a patient to perform and show any change, that would be the floor effect. So the most easiest example I could think of is if the Berg balance scale, if a person cannot even sit up without back support on their own, they just fall over, then they can't get past the first question on the Berg and they would score a 0. So no matter what you're doing in therapy, maybe they are getting some trunk activation, but they still don't have good balance. And so they would always score a 0. So you would have to get a different type of balance test for them. I'll let you look through these. Static postural control, just when you're still. Dynamic postural control when you're moving. And that's all. So I will say that you will probably be excited. That was only the first PowerPoint, but it's the hardest and it's by far the shortest. So what I want you to get out of that PowerPoint, I want you to know how motor learning occurs. And I want you to remember what neuroplasticity is, and that you've got to have repetition for neuroplasticity. And I want you to know the different types of tone, like dystonia and hypertonicity, this hypotonicity, and the difference between upper motor neuron and lower motor neuron. Now we're going to keep using all that with each of our pathologies when we hit those, but you need to understand them now, okay? So you're all brain fried right now. I can see it, and I am a little bit too. So let's take I'm going to pause the recording. I just saw that I wasn't recording those last few slides, but I've just started. So I cut a few slides off, but this is where the good stuff happens. So it won't really cut anything off. Sorry about that. So we know neuroplasticity is the brain rewiring itself in response to repetition, practice, and practicing the right way. Compensation is when you use substitution patterns to get a task done. So this would be if a person that has a stroke and they never really get the kind of care or rehab they need, say instead they may use most of the use of their right arm. Well, they never get the right type of therapy, so for their arm, so neuroplasticity doesn't happen in their brain to get their arm working again. So they just start doing everything with the left hand side of their body. Well, over time, their posture is going to change because they're always reaching across midline, always doing lateral bending. Their muscle bulk of their left arm is going to increase, and their flexibility is going to decrease, while the muscle bulk of their other side may stay the same if it's upper motor neuron because of the hypertonicity, but they may have postural changes. Maybe they'll start having leans, and eventually compensations almost always bring about overuse injuries. So like overusing the shoulder, doing a weird movement because you're not doing it with two hands like we're meant to do it. Transferring without scooting forward, or just I've seen somebody transfer before. They wheel their wheelchair right up directly in front of the mat, put on their brakes, and then they just basically, I don't know how he did it. He just catapulted himself out of the wheelchair in one motion onto the mat and landed in a ball. That was compensation, of course. Okay. This is just some definitions formal definitions you can look at. Compensations are behavioral substitutions. You're just using whatever muscles you have left over. And there's little to no emphasis on regaining use of the injured and involved extremities. So compensation is just using whatever you have left over to get something done. Now, I will tell you something. In the neuro world, when you're working with patients with neuro injuries, compensation is almost always a bad word. You never want to teach anybody how to compensate with a task. We almost always want to do things in the right way, even if it's harder for them and we have to do a lot more work, because that's the way we get neuroplasticity to take effect. And if the neuroplasticity takes effect, then they will have the ability, and then they will regain some of the use of that injured part. We do neuroplasticity through, and let's say that a limb was totally paralyzed. We would do that through external sensory stimuli, putting them in what we call weight-bearing positions. So if say your arm is completely paralyzed, well, I'm going to support your arm, and I'm going to have you lean, sitting on the side of the mat, leaning all your body weight on your paralyzed arm. I have to support your shoulder and your elbow and your wrist so that you don't fall over, but I'm putting your body weight through your paralyzed arm. Even if you're just leaning on it, you're sending sensory information through that arm to your brain saying, hey, we know there was some damage there, but hey, I'm still here. Repair me. I need help. That's how you get the brain to start making neuroplasticity. Different types of neuroplasticity we'll go through. Don't get too hung up on these different words. Vicariance just means that sometimes different and underutilized areas of the brain might take over for the functions of the damaged lobes. So some parts of the brain that may be less important may suddenly see, oh, that important tissue was damaged, so we're going to take over for their motor programming. And so that's called cortical remapping. The brain remaps its wires. Redundancy is saying that when the CNS has a backup system when things go down. So that's how neuroplasticity happens, that when we stimulate the body, we stimulate the backup system. I don't think many people believe in that redundancy much anymore. Most of us are kind of followers of the function-induced recovery, or cortical use-dependent cortical reorganization. And that's just the process of reprogramming the process of reprogramming parts of the brain to recover from damage. So example is what we call forced use activities. And you're going to hear us say forced use activities a lot and weight-bearing activities a lot throughout the rest of the course. All that means is taking a paralyzed extremity and putting it and forcing it into a position that it has to bear its body weight, usually a lot of your body weight. And now that doesn't mean the person that has to control it on their own. We're supporting the joints to keep them upright and from falling over, or keep their knees straight and their hips straight so they don't fall over. But the longer we can keep weight and pressure going through a paralyzed limb, then it's just sending more and more signals to the brain. So that's what we call function-induced recovery. It's recovery that is induced by the need for function. It's in the name. How do they facilitate recovery? You're going to use Therex and neuromuscular facilitation to reduce sensory motor deficits and promote recovery and function. So neuromuscular facilitation, Therex, and you can use the principles of Therex still apply in the neuro world. You might just have to use them a little bit differently, but the basis of everything Dr. K is teaching you is still the same here in the neuro world. Just things might change a little bit because the injuries are different. Facilitation means setting up the neuromuscular system or a limb in a way that it can perform optimally. So doing these things simultaneously will prevent what we call learned non-use, which is basically when the brain teaches itself not to use a body part or extremity. And that's a type of compensation. So if you have a paralyzed arm or leg, and then you just decide it's easier for me to go through life just using my other side, I don't want to work hard and try to get a little bit of muscle back, then it's gonna be a compensatory strategy, and eventually that will turn into what's called learned non-use. And in that time, the brain will no longer be able to learn how to do things the right way. So if somebody has been compensating and has learned non-use for a few years, and then they come to therapy for gait training, well, their compensations are so hardwired into their brain that you're probably never going to get them to walk right. You'll probably never untrain those compensations because they're so hardwired. I'm not going to say never, but that usually is the case. Okay, let's just talk about a few different types of function-induced recovery. What we're doing in lab this week, tomorrow and Thursday, and next week, is called PNF, and it stands for proprioceptive neuromuscular facilitation. So PNF is basically, if you watch my videos, you should have watched them already. If you haven't watched them yet, please watch them tonight before you show up tomorrow. They're a set of limb diagonal patterns, moving our limbs in diagonal patterns that are not just made up patterns just for exercise, but they came up with these patterns based on observing people doing functional activities during many different daily home chores, occupational chores, and different everyday activities. And so they came up with these movements based on that. These are things that you can start off with very low level brain injury, spinal cord patients, and there's ways you can use PNF all the way up to high level patients. So we'll be learning those two things over the next couple of weeks. NDT stands for neurodevelopmental treatment. This was developed by a couple of German doctors. They were husband and wife, and their last name was Bobath. Sometimes in the old books, this is still called the Bobath technique, but most books call it NDT, neurodevelopmental treatment, this is where all of the forced use and function-induced recovery is about. This is where you have a paralyzed leg, we'll stand them up on it and lock their leg into some brace, or you sit down and hold their leg into extension so they can stand and bear their body weight on it. That sends signals to their brain, and eventually those muscles will start waking up and you'll get some cortical rewiring, and then you'll start getting muscle activation again. Takes lots of repetition, but that's how neuroplasticity happens. NDT and PNF are all about neuroplasticity. A little bit more, I'm on them. The Brunstrom technique is a little bit like, it's an older technique, and it's a little bit like the basic PNF diagonals, but they're basically just, it's for low-level functioning patients, and they just use basic limb strategies. And then as they get stronger, they just move to more complex limb synergies until they get some kind of normal movement pattern. This does use a lot of repetition and stretching and tapping. So when we talk about, when I use that word neuromuscular facilitation before, sometimes we have to do a quick stretch on a muscle to get it to contract. Sometimes we'll tap on it with our fingers, or we'll squeeze it with our fingers. Stroking, like just with your hand, just rubbing the muscle deeply with like just a little bit of pressure. Sometimes putting like a warm hot pack on a muscle sometimes can kind of warm it up before you do anything. It can help lower some of the hypertonicity and stuff. So we can do those with Brunstrom, but that's basically all Brunstrom is about. Sensory stimulation is just using things like, you can put quick ice on a muscle, on a person to make a muscle contract. So if you remember back from PTA techniques, there was a controversial thing in your book that I didn't believe, but your book said. It said that ice would lessen muscle spasms and decrease hypertonicity. Well, the sensory stim theory says that quick ice facilitates a muscle contraction, which I've always seen and believed. So I think what the difference was, quick ice in the sensory stimulation, the sensory stimulus way of neuromuscular facilitation turns on the muscle Golgi tendon organs and makes a muscle contraction. Whereas prolonged ice just relaxes it after a long time. So that's maybe the difference if you were wondering. But if we're using ice for neuro, anything with the neuro world, we're doing quick icing to kind of shock the system with that temperature to get a muscle to contract. And sometimes that will happen. Not done as much anymore, but it used to be done. Okay, so I gave you a few techniques there. How you know which one you should use? Well, really, there's no right or wrong answer. You use whichever one works best for your patient. Not everybody is going to respond to the function-induced recovery, where we put them through different functional tasks over and over again. Some people will benefit a lot more from NDT and force use. Some people might do better with the sensory stimulation. So it's just, but honestly, it's a mixture. You're never becoming a follower of one theory or the other. There are some therapists out there that they only follow the NDT principles, or they only follow the PNF principles, and they think all the other theories and principles out there are junk. They only treat their patients like that. But the facilities that have the best patient outcomes and win awards and are model centers, their therapists use a combination of all of them, because not one technique is going to work for every single patient all the time. So you use a little bit of everything. But I will tell you, just from my experience, and probably Ms. King would probably agree with me, that in the NDT and PNF are probably going to be where most people would get the best outcomes and recovery from. I'm not going to say every time, but the most of the time. At least start them off on that, and then maybe if they're getting better quick, then you can move into other ways. Your hands are important when you're doing neuromuscular facilitation. You can't just be holding the person from wherever you want to, because our hands give sensation on their skin, and we may confuse their brain. So usually we put our hands on the muscle that we want to contract or stabilize and work. So if I'm trying to get my bicep to turn on, and if I'm trying to get my patient's bicep to turn on during a bicep curl, I might put my hand on their bicep and squeeze, or I might tap and just keep tapping with my whole fingers over and over the whole time they're doing it to facilitate it. But if I was just holding their arm like this in the air and resting my hand on their tricep and asking them to do it, well, I'm giving a lot of pressure to the antagonist muscle. But I want the bicep to contract, but I'm squeezing the triceps. So I'm giving confusing signals to the brain. So that's where you have to be sure you know where your hands are at the right time. So your hands only need to go on the muscles that you want them to go on. If you're trying to get somebody to work on neck extension after a brain injury and they can't hold their head up all the right way, you would have them in a prone position or a forward leaning position, and you would tap the back of the head. Not the back of the head. You would tap the neck extensors, or you would stroke the neck extensors from the base of the skull down the cervical spine, and that's how you would facilitate them turning on their cervical extensors. If you were holding their head and then you were holding them like this, you've also got your hand on their flexors. Well, that's just confusing the brain. You're giving too many signals, so the brain wouldn't know what to do. This will remember this, if you don't understand this now, this will make perfect sense when we get to gait training with neuro patients, because when you're gait training with neuro patients, your hands are constantly moving all over the place with every cycle, and your hands have to be in the right place at the right time and in the right timing for everything to go right. It'll make more sense then. I already told you some of these tips for facilitation: tapping on a muscle belly, stroking the muscle belly in the fiber, in the direction of a fiber contraction, giving pressure by squeezing, quick icing I talked about. We'll talk about rhythmic rotation in lab, and then the guided PNF patterns, which we talked about. Sometimes if you're doing some work with somebody and you're trying to do some force use or facilitation and it's not working, you can start with some PNF diagonals real quick, and then things will start just kind of flickering on, and then you can go back to what you really meant to do. Sometimes that works, but that'll make more sense in lab this week. Okay, always remember, no matter how good your session is going and how injured or non-injured your patient is, their hypertension is always going to be there, and it's always going to get in your way. There's always going to be things you want to do that you are having trouble doing because hyperintensity is there or spasticity is there. So how do you get rid of it? Well, the first way is prolonged stretching. So any muscle that is having spastic or hypertonic, you can stretch it. You're not going to be able to stretch it really hard because that's just going to make the tone worse. But low load prolonged stretching, like you learned from Dr. K. And when I say prolonged stretching, it could be anywhere from a minute up to 5 minutes of stretching to get that muscle to relax, but it might take that long. Prolonged stretching. The faster you try to stretch it, the worse you're going to make the tone. Neutral warmth over a segment. This could just mean taking like a warm blanket or like a hot pack that's been wrapped in hot pack layers and putting it on a muscle to help tone down the cool down the hypertonicity. You can do casting. We used to do casting on hypertonic muscles to if a person had their hypertonicity and their dystonia was keeping them in such a flexed position, say a plantar flexion, and there was no way, and we would try to do gait training, and their plantar flexors were so spastic that they only could stand on their toes. The heels never reached the floor because they were so spastic. So we would cast them, we would stretch their plantar flexors for a long time until we could get them into a neutral dorsiflexion position. And then we would real quickly put them in a fiberglass cast, just like the same kind of cast when you break their bones. And this was part of their therapy. And then we would leave them in those casts for like 2 or 3 days. That's a very long, prolonged stretch to the plantar flexors. Well, that always not only gives you more range of motion, but it really lowers down the hypertonicity too. So you can do that. It's most often done at the ankles, knees, and at the wrist and the elbows. You can use neuromuscular electrical stimulation to reduce spasticity, usually on the antagonist. So like if my bicep was really spastic and I couldn't extend my elbow, I could use the nerve stem on my triceps and maybe get some reciprocal inhibition of the bicep tone. And then there's lots of oral meds for spasticity. They all make you sleepy. And so think about if you have a brain injury or a stroke and you've already got some cognition issues, well, we don't really want to put you on medicines for your spasticity. They're going to make you sleepy because now your cognition is going to be even less so. You're going to be even more confused. So those people will take injectable medications, like the most common injectable medication for spasticity is Botox. Same Botox you get for wrinkles for cosmetic reasons. It's the exact same stuff. It's the exact same stuff. Same company sells it, same pharmacy, same company called Allergan makes it for whoever buys it. There's only 2 types of Botox type A, and they're approved in the US now. There's a couple of other types, but they're not as pure and they're not as studied as well. The other injectable med for spasticity is an actual implantable pump that is implanted surgically under the patient's skin and then hooks into their spinal cord. And the pump has the liquid medication in it, and it's about the size of a hockey puck, and it goes down under their skin, and it continuously delivers the medication called baclofen to the intrathecal space around their spinal cord, and that goes straight to the spinal cord in the brain, relaxes spasticity, and it bypasses the rest of the body, and they never get sleepy at all. So a lot of people that have bad spasticity end up getting what we call a baclofen pump, and those have to be refilled every 3 to 6 months with a needle injection. They're wirelessly programmable with a computer. You can have different types, different dosages at different times of the day, different seasons of the year. People's spasticities get worse in the winter, so they may go to the doctor to get their programs to have more dosage in the cold months versus the summer, things like that. Pretty cool. I'll try to show you a video of that when we get to the pathologies. So now you get muscle strengthening. You got muscle return. Great, you did all this force use, now what? Now is when Therex comes in. So after you do all your forced use, you get a little bit of activation coming in. Now everything that Dr. K told you starts. Work on isometrics, then eccentrics, way before you go to concentrics. Work in functional patterns, work your core muscles before you start working your extremities, all those things, just like Dr. K taught you. A little bit about, we're almost done, 2 more slides. A little bit about fatigue with neuro patients. So think about how when you fatigue after a workout, that's just a normal bodily fatigue where our muscles are tired, we can't lift the weights anymore, or they're getting really heavy, those kind of things. Well, when you have a central nervous system injury, fatigue is a little bit different. So there's a certain thing as central nervous system fatigue. That's just a damaged central nervous system, and I'm talking brain or spinal cord, either one, that has some damage to it that we're stimulating through the right type, and it's being stimulated in the right type of way with us doing our facilitation, but we're doing it a lot, and after a while, the synapses and the nerves are just over. They're just done. Like there's just not a lot of there's just not a lot of neurotransmitters left. We're reabsorbing a lot more of our neurotransmitters at that neuromuscular junction, not making as much force. The brain and spinal cord are just getting tired because, yeah, you're paralyzed and you're having to work hard. So it's a physically and a mentally demanding thing. So your muscles get tired and the concentration part of it. So make sure you give your patients frequent breaks. Now, I'm not talking like give them a break every minute, but in the beginning, you'll get seeing a patient, you'll be able to gauge how much endurance they have, and then you'll be able to give them their breaks. But then as you go along, you should be giving them fewer and fewer breaks. And never get caught up with a patient that gets you on a break schedule, like every 10 minutes or after we do every activity, we take a break and get a drink of water. Don't do that. This is just a little bit something I'm going to let you read on your own. This is just a little bit about feedback and practice, and more for motor learning, and for making neuroplasticity stick. You can read through this on your own. And that's the end of the PowerPoint. Now, any questions about motor recovery, about the different types, like about neuroplasticity and all those new words that I said? It's pretty cool stuff if you stop and think about it. It's all chemical. It's just all neurons rewiring and the brain rewiring itself. So it's a pretty cool thing. Now, have most of you went by? I was at school Friday, and a lot of y'all, about half of you came by and got your lab books. Did anybody go by today or yesterday and get your lab book?
I just drove into Houston today, Mr. Allen, so I can
Okay.
go pick it up tomorrow if.
Well, that's fine. That's fine. Okay, so remember that the only reason I'm asking, you've got the videos and all my handouts that you need for lab tomorrow. I think that's more than enough. The book just adds more pictures and a little bit more text to go into it if you want to, that it'll have. But there is going to be some information from chapter 1 of your lab book that's going to be on your lecture test. That's a week from today. So remember, we have our first test a week from today. And it'll be over the lectures from last week and this week, as well as the things we do in lab. And there are some things in the first chapter of your lab book I want you to know. And I'll write this up on the lab board when I get to the school in the morning so everybody in lab can see it this week. But go ahead and make note of these things now. In chapter 1 of your lab book, you need to know the different types of practice. There's many different types of practice. You need to know the different styles of feedback. There's many different types of feedback. And you need to know the stages of learning. And we went through the stages of learning today, cognitive, and then autonomous and all that. But you do need to know those things from chapter 1 of your lab book. Otherwise, everything that you need to know is we've lectured through it live, or it's videoed, and then we'll go through it in lab. Okay. Any last questions? Okay. Sorry to keep y'all so long, but y'all hung with me. So, what I want y'all to do now, I'm saying this, I'm not trying to say this to scare you. I'm saying this from experience with other cohorts. Don't let this first little bit of info of neuro, don't just let it slide by. You've got to understand it because these are brand new. Think about when you were learning kinese and learning Therex for the first time. They were these brand new concepts. Learning these things I'm teaching you are brand new concepts. So if you don't understand neuroplasticity, and if you don't understand the parts of the brain now, you're going to be completely lost in everything we say starting next week. So make sure you know those things, okay? So if that means we have a meeting at school or we have a long one-on-one meeting going over things, I will do that. You just got to email me and let me know, okay? We are planning, I shouldn't open the bag on that yet because I don't know if I have permission to say that yet. So hang tight. I'll let you know when your first open lab will be. I may have information on that tomorrow or Thursday, but either way, watch your videos in lab and we will do them for lab this week. So tomorrow or Thursday. So if there's no questions, you may go.
Thank you, Mr. Allen.
All right, thanks guys.
Thanks, Mr. Allen.
Bye.